And as caregivers, we think of clinical manifestations and we're very familiar with them. But sometimes in the heat of the moment, or when you're taking care of patients that are in the hospital, or if you're a family member that's out with someone at home, you may need a quick method for identifying stroke. And the best thing that we can do with stroke is to prevent it. But if people are having symptoms, the best thing we can do is treat them very readily and get them to the hospital as close to the time of onset, because there is time limits that I will expand on that you literally need to be aware of, as well as teaching families about that. So this is an acronym that everybody uses these days that was developed for teaching patients and families, how do you really assess this quickly? You look at FAST, which is face, arm, speech, and time. And for face, you're going to ask the patient or the person to smile. Of course, you're looking to see if they've got facial drooping on one side, and or a change in their ability to make a complete smile when asked. In terms of arm, you would ask the person to raise both arms, and that way you kind of see how much independent ability that they have. You may see one arm with no ability to raise. You may have one that can raise, but they can't sustain it being held up or held up at the same level, and that's considered a sign or symptom. And then also speech, of course we're looking for slurred speech, and sometimes you can explain that to a patient's family, like, they're either slow to speak or their words don't sound exactly right. That's kind of common. And then time, again, is to really educate patients and family members that if any of these signs are observed, we need to call excuse me, we need to call 911 immediately. Now, also realize that, and you notice this little sign to the side, it says dial 999. That is there as a reminder, just to be sure that you're making yourself aware of what is the actual internal hospital plan for if you notice an inpatient that has these symptoms. You need the exact same fast response, okay? So you need to know, is there a certain number? Do you call a rapid response call? Do you call a specific overhead announcement for code stroke? You all have a homework exercise for this week in clinical that's located under week 4 resources. It's called CVA exercise. And take that with you to clinical this week. I'm going to send a copy out to the clinical instructors because you guys need to go with that and kind of make sure you really understand not only like what can you find out about how they handle a code stroke in the facility, but also to kind of see, do people really know that protocol real well in the units or not? What we've found is that if you come into the ER, they've gotten this process down pat. Sometimes on the floors of hospitals, the speed and the hour requirements are not well understood. So see what you think and what you find and let me know. These are just the typical diagnostics that are done. You'll see more of this on the algorithms as these things are ordered. CT scans are the main thing that you want to do. The best ones are done with infusion. We learned in patients with diabetes that are on metformin, that can create some issues with infusion. Sometimes they may order MRIs if the CT scans are not real definitive. If they think the source of plaque or a clot is coming from the carotid arteries being occluded, they may do Dopplers, and then other different tests that are done. Echocardiograms are often done to kind of evaluate whether there is an issue with flow or valve problems that could be associated with clots that are forming in the heart. And often they're looking with the echocardiogram to see if that is the source of what might be causing the strokes to occur and reoccur. So that's a good education point for families. And then you're going to see a lot of different lab tests, usually your typical panel of labs ordered. Obviously, we'd want to know what somebody's hemoglobin is if we thought they were having a hemorrhagic stroke, or if we're getting ready to give somebody thrombolytic therapy. Either one of those, you want to know your baselines. And secondly, you're going to see that with preparation for someone for this type of procedure, when they're going to go on thrombolytic therapy, you want to be able to know what is your baseline coagulation before you start that, because you want to make sure they're not in some hypercoagulated state already. Medical management is usually going to be thrombolytic therapy. They may put patients on neuroprotective drugs to kind of calm down the nervous system firings. There are some surgeries, and you'll see some pictures of these. Mainly, we won't have lots of test questions, but just to kind of know what types of therapies are out there surgically. Make sure that you're very, very clear. You can look at this algorithm for advanced cardiac life support. You'll see other examples if you Google them. Pretty much the most current ones are going to all cover the same typical things. You want to activate the EMS system if you're out in the field by calling 911. If you're in the hospital, you're going to want to call whatever number or call a code stroke. Wherever, if they're EMS, then they have certain specifics that they're going to do in terms of their assessment. They're probably going to check a glucose as well, just to make sure there's not an issue there that's contributing to it. Alert a hospital and bring the person in. When they arrive to the ED, the general assessment and stabilization, you want to know their vital signs, their ABGs. They're going to get IV access in if they don't already have it, get labs, get a 12-lead EKG. They're going to put them on oxygen. They may check a glucose and treat if needed there. And then they're going to do a neurological screening assessment. There is a scale in your thing here that is pretty much the standardized thing that you see used here. And then they're going to order an MRI of the brain or emergency CT scan, and then they're going to activate the stroke team. So once the stroke team arrives, and they've got a guideline, and you notice that that entire assessment of all those labs, EKG, IVs in, order for a scan, and all that is supposed to be done in 10 minutes or less. ED arrival, within 25 minutes or less, the expectation is that the stroke team has come in, done a full assessment, evaluated the stroke scale themselves, and then make sure, again, validate the second time, when was the symptom onset. Because the goal is to get patients started on recombinant TPA within 3 hours or less of symptom onset. If it's been longer than that, it kind of disqualifies patients from taking it sometimes. So the big thing with the CT scan is, do they have signs of a hemorrhage stroke, or is this an ischemic stroke? Obviously, for a hemorrhagic stroke, we're not going to start any thrombolytics, because that could make the hemorrhage worse. So for people that don't have a hemorrhage, then we're going to do some additional things. We're going to, again, repeat the neurological exam. Is there any improvement in the deficits? And then we have to review exclusion criteria. And if they meet, if they're not a candidate, then because of that exclusion, they may give the patient some aspirin and then admit them to the ICU. If they still meet the criteria, then families have to sign consents, or the patient if they're alert and able to do that. And then there's additional things about, they can't have had any antiplatelet or anticoagulation treatment prior to that. And then they will go to have they will have the TPA administered, and then admitted to the ICU following that, and then having their neurostatus and blood pressure frequently evaluated. These are things that you would normally see in terms of indications or exclusion criteria from receiving thrombolytics. If it's been greater than 3 hours since symptom onset, if there's evidence of intracranial hemorrhage on pre-treatment CT, which we've just said, if there is a clinical presentation that is suggestive of a subarachnoid hemorrhage, if they have any kind of active internal bleeding, if it's been within 3 months of any intracranial surgery, serious head trauma, or a previous stroke, or on repeated measurements, the blood pressure is way high, greater than 185 for systolic, or greater than 110 for diastolic. If they've had a history of an intracranial hemorrhage in the past, or they've had a known arteriovenous malformation or aneurysm. So all that has to be assessed before any thrombolytic therapy could be started. So this is just telling you, again, about the eligibility criteria that we just talked about, but this is like one of the main things that we're trying to get done within 3 hours if they are a candidate, to open up that area. These are just some other drugs that may be given, of course, anti-anxiety meds, anti-epileptics may be given. Sometimes the patients may have pain and need pain medication, and stool softeners again, so they're not straining. These are just some pictures that show you a little bit about what a carotid endarterectomy accomplishes in terms of removing plaque. The big thing with that is watching to see if your patient, has any issues, because you have cut into an artery and repaired it. So watching for problems with that is important. This is just a picture of what the extracranial intracranial arterial bypass looks like. And typical complications that you can see from some of the surgeries as well as from some of the strokes. Hydrocephalus, where there's more fluid on the brain, creating more pressure and potential for not only seizures but more ischemia or problems. They can have rebleeding or rupture. They can also experience vasospasms that can mimic more symptoms of a stroke as well. These are kind of the key categories for stroke assessment. This is the most common one that you see, that's the NIHSS, and it's the National Institute's Hospital Stroke Scale. This may be on a form or a check sheet when you're doing it quickly in the ED or something, but it's often going to be in your computer system so that it's being done after a stroke ongoingly to evaluate the condition post interventions as well. Again, nursing interventions are going to include neurovascular checks, using the stroke scale. In ICUs, they may actually be monitoring intracranial pressure, but you won't see that in the regular units. You're looking for safety for that patient because one side may have unilateral neglect that needs protection with movement and activities, emotional support, education to the family. And I won't read all of this to you, but this is the typical things that are really done for stroke prevention, which really kind of address all of the major risk factors that we've already mentioned. And then stroke recovery, these are some facts. So to share that type of thing with patients and to kind of be aware of what they need to know going home. And then lifestyle changes following stroke. So make sure that if you're doing teaching, you're really getting into all of the essentials with this with them.